Hello everyone, and welcome to CK Med. My name is Clark, and I'll be taking you through MSK, back and spinal nerves, and autonomics today. To start things off, first you need to understand what is the back for. And this is sort of a little bit common sense, but we also want to apply it obviously medically, so you can think of the broad picture when we're talking about the back and the spinal nerves. And so the purpose of the back is pretty much to stabilize the body, the stance, and have attachment points for muscles, allowing for the limbs to be able to move appropriately on this stable structure. It also is important for attaching bonus processes such as your ribs to protect vital organs such as your heart and lungs. And this is something, the back and spinal nerves is a major clinical presentation in the doctor's office or the emergency room or your operating room. It's something that's dealt with all the time. Back pain is so common that think of it as it's pretty much going to be in reference to about 5 questions on your step 1 and very important for your anatomy course right now. So again, just talking about back pain, it occurs in all different places. There's the cervical spine, the thoracic spine, the lumbar spine, and the sacral spine. And kind of what I want to do is break down how to kind of find the different types of vertebrae. We'll talk about the different pieces of vertebrae, and when you see one sitting on the table in your anatomy lab, to be able to kind of really pinpoint where this is from in the body. In addition, that if you have any imaging, such as a CAT scan or something like that, you'll be able to spot at what height or generally what area you're actually looking at in the picture. And this is super important when it comes down to answering a lot of questions, especially on your BSc 1s and BSc 2s and those sorts of things. And so as far as vertebral function, we're going to break down each of these that we have here. And so one thing that we like to separate as far as vertebra are going to be your cervical vertebra, your thoracic vertebra, and your lumbar vertebra. Your sacral is a section here, but it's kind of its own little thing, so we'll be talking about that later. But as far as these 3 vertebrae, you might just have them sitting on a table in the lab, and they might be pointing to different pieces of this, or they might be asking what part of the body did this vertebral body come from. And so some things that really can kind of give it away are certain things that the other vertebrae don't have. Or differences in sizes of different things. And so one thing that I kind of highlighted here in the cervical only is that the cervical vertebrae in your neck are the only ones that actually have these transverse foramina, or these little eyeballs on the side here. And you might be thinking, what on earth are those used for? Well, you have your heart down here in your thorax, and off your heart you have your aorta. And off of your aorta, you have an important structure known as your subclavian artery. And subclavian will eventually turn into your axillary artery and then into your brachial artery and go down to your arm. But off of your subclavian, you have a few branches, and one of them is called your vertebral artery. And your vertebral artery actually comes right up through these transverse processes, and it's protected by these ring structures of vertebrae, and that will then go up and supply the base of your brain and the ventral body of your brain and your brainstem, these arteries, and you'll be learning that when you get to your neuro section in term 2. So I just want to spot out, if you have a CAT scan, you'll see these pictures actually in a couple slides, that when you see these eyeballs on the sides of these transverse process, in addition, you have this kind of fishtail structure right here, that is going to be in your cervical region, and that's when you're looking at the neck in an image or a CAT scan. The next is your different body structures found in your thoracic vertebrae. Now, each of these, even including the cervical, have different things. You know, the spinal canal, they have the body, the lamina, and the pedicle, but it's really nice to emphasize it on a very specific structure, and this is your thoracic vertebrae. And why I want to show you this is it really emphasizes each of the pieces of a vertebrae nicely. And so posteriorly on the back of you, if you were to kind of bend forward, you might have little spinous processes. If you're thin enough to see someone's spine, you'll see these kind of poke out, or you can feel them, or you can rub them on the back of your chair like I used to do in elementary school, and then make that weird kind of sound. But I don't know if anyone knows what that I'm talking about, but yes, the spinous process is the thing that is most posteriorly, and you can see that very nicely on a thoracic vertebrae. The thorax is also very important for attachment of ribs. And so ribs really need a nice housing structure to attach to and be stabilized and held tightly to. And that's going to be our transverse process, which is this side here. It's a nice attachment, a very long transverse process, very fat and heavy transverse process, so that the ribs have a nice, strong attachment point on the vertebral column. And that's what those are for in the thoracic region. And then in between the spinous process and the transverse process is where the lamina is found. And so if someone has kind of spinal stenosis, they have very bad osteoarthritis of their joints, including the spinous process, they'll have all these things and attachments that grow off here that will narrow this canal, and these are called osteophytes. And this is a problem because it can damage the spinal cord running through here. They might have neuropathy and pain and stuff like that that radiates out towards their limbs or their chest wall or whatever. This is something that we can actually go in and cut this structure, and so we can do a laminectomy. And so a laminectomy is just going to relieve a little bit of that pressure just by cutting right through the lamina. And usually we don't have to cut it on both sides, it's just on one side, and that will relieve a little bit of pressure. And then we have something called your pedicle, which is between your transverse process and your vertebral body, which this is the vertebral body down here. And the vertebral body is really the base of each of your spinous processes. This is where it has the most strength and stability. It's kind of the column of your spine that your whole entire body's weight is found to lay upon, is laying on top of these bodies, and then you have intervertebral disc laying in between each of those. That's kind of the memory foam of each of your vertebral processes. And then the pedicle is just the thing between the transverse process and this, and it allows us to continue making this circle in this spinal canal for the spinal cord to run through. And that is pretty much actually the basics of all your vertebra from your cervical down through your lumbar. It's a little bit different in the sacral region because that's one giant fused bone, but this is kind of a concept that you can apply to all these different things. And so in order to differentiate your cervical from your transverse, remember you have these rings on the side for your cervical and the fishtail on the back for your cervical. And then in the thoracic region, you have very fat transverse processes. Where now when we get down to the lumbar region is an attachment of heavy back muscles. So these things are like inside your abdomen or your psoas muscles, and then you have all your heavy back muscles on the back, such as your levator spinae muscles. Levator spinae muscles go up into your thorax, but they're strongest and most muscular in the lower part of your lumbar region, because this is where the stability of your entire back kind of comes from. So if you're ever wanting to kind of work out some muscles for your posture, it's nice to kind of start with your lumbar region and then head all the way up through your thorax and through your cervical region to kind of get everything kind of stabilized. But as far as the vertebral body in the lumbar region, this is going to be something that has a giant body, and that's why I emphasize this giant body. If you see something in an image, such as a CAT scan, with a giant body and kind of smaller structures that don't fit the size of this, that is going to be in your lumbar region. In addition, in the lumbar region, you actually have this extra facet or side facet. So I have my transverse process, I have my spinous process, and that's all we had in the thoracic region, which is here. In the lumbar region, however, we have this extra kind of miniature spinous process that kind of projects off here, and this allows for extra stability in the lumbar region to make sure nothing kind of slips or breaks off one another. And we'll be coming back to this actually when we're talking about clinical spondylolisthesis and spondylolysis, when we look at those images. But that's what these facets are for extra attachment and strength in the lumbar region. And so if you're looking at an image and you go spinous process, transverse process, and then I have another process coming off, you're now in the lumbar region. And obviously there's other things in these areas, such as abdominal organs that you can spot, like the kidneys or spleen or stomach or something like that, that will kind of point out and help you recognize, oh wait, yes, I'm in the abdominal region, so it's got to be my lumbar vertebrae that I'm talking about. Okay, so now I want to kind of give you a little bit of three-dimensional representation of some of our specialty cervical vertebrae, and then go through the ones that we kind of just went through, but with a little bit better three-dimensional pictures. And we'll go through these sort of quick. And so you actually have two specialty cervical vertebrae. So your cervical vertebrae are from C1 to C7. Your thoracic vertebrae are from T1 to T12. Your lumbar vertebrae are from L1 to L5, and your sacral is a 5 fused bone, along with your coccyx, which can be 3 to 5 pieces. The coccyx is not very important unless you get a little tailbone bruising from falling or something like that. But as far as our cervical region, we have two special ones. The first two are actually very important. And C1, known as your atlas, and C2 as your axis, these are two very special bones that you need to understand how they work and what they work for. In addition, remember their names associatedly. And I always have this trouble remembering atlas versus axis. I always switch C1 and C2 around for each of these names, but until I really sat down and thought about it. And if you can remember atlas, which is that big, burly, strong guy, which is not really the stick figure, but he holds up the world that comes along. You know, I really don't know how to draw the world or whatever. This is Africa and Europe and stuff. Okay, and then Asia. So Atlas is the guy that was really strong and burly, and he was the one in Greek mythology that was lifting up this world, right, on his back. And so if you just think of this, what is the globe of your body? And that's going to be actually your head. The head is going to be the globe, and then therefore the one vertebral body that is holding up the head is going to be the first vertebrae, which is my C1. And that is going to be the thing that's holding up the globe, therefore his name is Atlas. He's the one that's holding up that globe. Where C2 is going to be the other weird name, which is axis. And this is actually very important because when I lay this bone on top of this one, this part right here, this is known as your dens. And your dens is something as a pivot point. You can see that this slides in actually right here. It comes up, it goes through here, and this is my dens that comes in here. And this is sort of a pivot point. We spin around this kind of merry-go-round, or like, I don't know, one of those little poles or whatever that you're dancing around, those, you know, those dancing poles. But that's what actually is happening with C1 and C2, is they pivot along each other, and this allows you to actually turn your head from left or right. You might be asking yourself this question actually, is how on earth do I have my neck being, do I have bones allowing themselves, if they're just sitting right on top of each other, how do they actually allow themselves to kind of make this nice rotary rotation when there's only 7 vertebrae? It's not a very long thing to kind of pivot along. If you look at if you sit down in a chair and then you turn your body from left to right, that doesn't have that great of a rotation, where your head actually has a very good rotation. And so this is actually kind of a pivot point along the dens, an attachment up here into my C1 atlas that allows for our neck to have a little extra rotary rotation there. And so those are the two kind of specialty bones that we'll be talking about in the cervical region. And then from the remaining, we actually have what we were describing before. Oh, I look directly at this vertebrae, I have a small body, I have these transverse processes. Wait, I see fishtails, and I also see rings. If I see rings, what did I say that was occurring in? Well, that's going to be my cervical region. What does that look like on image? Well, let's look at this. I see fish bones, I see rings, I must be in the neck, and I can look at other structures. I see muscle, 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 and then I have this dark space which is filled with air, and you might ask yourself, what air circular pipe is found in your neck? And that's going to be your trachea. And that is something that you can actually spot just simply by looking at a CAT scan. I have my cervical vertebrae, I have airway, I might point at this and go, what is that? That is going to be my trachea. And now I know that I'm in my neck. Another thing is, again, I look at a vertebrae. This one doesn't have the fish on it. However, it does have the rings, so therefore I'm in my cervical region. And we must be transitioning from a fishbone tail to a single tail. And where do we see that single tail? The next lower down area, which is your thoracic. So this is actually your last cervical vertebrae. This is C7. And you can actually, if you run your fingers down the back of your neck, if you start up on the top of your head and then slide all the way down the back of your neck, you're going to hit one spinous process that kind of sticks extra out. And this is going to be your C7 spinous process that pokes out right there. And that's actually kind of a reference point when we're palpating the person's back to start then counting your thoracic vertebrae following down. All right, and now next we have our thoracic vertebrae. We already kind of pointed this out. We have our vertebral body, we have our pedicle, we have our lamina, we have our spinous process, and very heavy duty transverse process allowing for ribs to be attached like this onto these guys and go around and protect our vital organs. And if we were to look at this kind of sideways, we can see the spinal canal going right down here. We have attachment points for the vertebrae above, vertebral body, transverse process. This is where the rib's going to come off and go this way. And then we have our spinous process down here. And if I were to look at it on an image, I can immediately first notice, okay, I have a large space, I have a cavity, I see this tissue here and this tissue here, and yeah, don't worry about the pathology, that's a pneumothorax. That's what that looks like on imaging. Then I have this large circular organ with different chambers in the middle down here, and this is actually our heart here. And so already just looking at the different organs, I can tell I'm in the thorax. In addition, I see bonus things that are wrapping around this way. So these are my ribs. That also tells me I'm in my thorax. But how about I just pretend I don't see any of this and I only look back here? Well, I can still identify that I'm in the thoracic region based on the vertebra, and that's kind of what I want to point out, is that actually is often the first thing that you can go to figure out at what height you're looking at. Sometimes people get all confused, especially in the abdomen. I'll show you those pictures because a lot of things look very similar and you don't know what you're looking at. So the vertebral process, or you're looking at your vertebral bodies, is kind of a big clue on figuring out where you are. So what are we looking at here? I have vertebral body, I have my spinal canal, I have one spinous process and two heavy-duty transverse process. I don't have an extra one here, and I don't have rings here. So therefore, I must be in my thoracic region. And that's just sort of some shortcuts I want to kind of teach you guys that you can kind of spot out here. And you'll actually impress the doctors in your anatomy lab if you can kind of point out these differences between each of the spinous, or the different vertebra. Okay, now we're a little bit lower, and I put up this image here to kind of pinpoint what we're looking at. So we have a very large body. This is a three-dimensional image of our vertebra. It's a very large body. We have our transverse process here. We have our spinous process, and then we have our extra facet over here. And this will tell us, look at this, how big this facet is right here. Facet, transverse process. And then we have this heavy-duty spinous process back here. And this is going to tell us we are now looking at the lumbar vertebrae. And if I were to look at it on an image, this is what I'm looking at. Large vertebral body, spinous process, two thinner transverse processes, not heavy-duty ones because there's no ribs attached here. And then look at this. I have an extra piece that comes off here. This is the one identifying feature, besides the giant vertebral body, that really kind of pinpoints and goes, I am in the lumbar region. So I just want to kind of point these things out kind of quickly, and please never forget them, because you're going to get anatomy pictures on your BSE 1s and BSE 2s and your CBSE in term 5, and even on your STEP. That's going to be showing you some anatomy pictures just like this in CAT scans and images that you need to kind of identify what you're looking at and can get to them very quickly and figure out what's going on. Okay, and last but not least, as far as the vertebral body area, are going to be your sacrum and coccyx. So your sacrum is actually a 5-piece bone that actually fused all together. So there's actually 5 pieces, S1, 2, 3, 4, 5, that comes down here, and that's why there's S1, 2, 3, 4, 5 nerves that come along with it. However, this fused bone makes this kind of weird shape. I don't really know how to actually describe this shape. But the sacrum is very important for the last stability, attachment to the pelvic bones, and that allows us to then attach it to our legs and be able to have a stable all the way down to the ground structure to hold your vertebrae up on. And so the actual base of your vertebra needs to be extra strong. And so that's why the sacrum is actually fused, which is quite important. The coccyx is not very important. There's no kind of weight on the coccyx. It's just like these extra bones sitting at the bottom. It could be anywhere from 3 to 5 different bones, but that's not that important. So in our sacrum, we actually have the end of our spinal cord actually ends up around L1 or L2 in adults, and then it gives off all our tail of the horse, chorda equina, and these guys kind of come in. This is all your S1, 2, 3, 4, 5 nerves, some of your lumbar nerves, and they come through and they kind of sneak out of these little foramen here as they go through this process, and then they go out to innervate wherever they're going. And that's actually why there's these holes here. And so you might be asking, okay, Clark, cool, whatever, that's the bone, and I should be able to know that that's the sacrum when I see it on the table in the anatomy lab. Yes, but what if I showed you an image and you look at this and you go, and you're trying to identify, other than looking at the vertebral or any of the bonus processes, you might be looking at all this and going, actually, I have no idea what this is. That is bowel. It's stool over here. This is stool, these little dark black bubbles. But that's not very helpful. Am I in upper abdomen? Am I in lower abdomen? Am I in pelvis? And so some identifying features, right? Because in the abdomen, you had your lumbar vertebrae. But if we go a little bit lower into the pelvis, then at this area, we can start to see the sacrum come into play. And the way I remember this is, see this little raccoon with his arms held high? Well, here's the raccoon right here. See him? And he's got his little dark eyes right here, right? And his little nose. And then with his arms held high. This is telling me that I'm in the pelvis. And so what these bones are this is my ilium. This is my sacrum. This is my other ilium. And this is actually just telling me that we're in the false pelvis, or upper, kind of at your hips, sort of, in this picture. But that's something that if you go and scroll down and you see that raccoon, you're going to be like, bam, I'm in the pelvis or lower abdomen. I know exactly what's going on here. And then you can identify if there's a break or fracture or whatever, that kind of gives that away. And actually, you'll impress a lot of doctors by having these fun ways of remembering imaging structures. And you'll actually teach a lot of doctors this. I've taught about 5 this week. Doctors that, oh, that's kind of the go-to when you get in the pelvis, is looking at the bonus processes, and that really gives away exactly what you're looking at. Obviously, some of the big organs like the heart, you're not going to miss when you're looking in the thoracic region. But when you're abdomen and pelvis, that kind of gives this away. All right, so now a little bit more about vertebral on a larger scale, rather than just kind of very focused. And so the vertebra is split into all these sections. We already went through cervical and thoracic and lumbar and sacral and coccyx. But one thing that we can do is actually break down curvatures. As you know, that our spine has different curvatures within them. Some are going forward, some are going backwards, some are going forward, some are going backwards. So you might be asking, does that have a name? And you are correct in thinking that there is, because there is. And so the way that we do this is there's only a difference between secondary and primary curvature. And how I assign these is I start from high, so I start all the way on the top with secondary curvature. And then I just alternate primary curvature, secondary curvature, and primary curvature. And then what you do is, what happens pathologically if one of these in a certain area gets a little extra curved? So this is the normal, nice and flow curvature. What happens when the thoracic and you hunch a lot and this becomes more like this? then that is actually an increase in primary curvature. And what we call that when we have an increase in primary curvature is kyphosis. And that is something, if you just think of a really old, hunched over person, that is what kyphosis is. And actually, after a long amount of time, if kyphosis isn't kind of worked on to fix, it actually kind of solidifies. And then the person actually will be kind of, you can't even straighten them out. They actually are bent in the primary curvature areas. And then if someone has actually increase in secondary curvature, for example, if the lumbar region kind of curved out a little bit extra, and you might ask yourself, why or when does this occur? Well, this is someone that might be pregnant with a baby and have all that extra weight right in the lumbar region that kind of yanks the weight this direction, allowing your vertebral bodies in your lumbar region to bend forward, and that's an increase in secondary curvature, and what we call that is actually lordosis. And so let's pretend this lady is pregnant, extra weight pulling this direction, therefore we have an increase in curvature, and now I would call this lordosis. And then there's one last thing is if I spin this column 90 degrees, and now I'm looking at it from behind or in front, if this lumbar or any of the regions in the thorax actually kind of bend laterally instead of too much forward or too much backwards, this is actually called scoliosis. And this is something that they did in elementary school to kind of check in PEs, they have you bend forward or whatever, and then the PE teacher or whatever was just measuring to make sure that none of your spines are kind of bent in any lateral deviation or anything like that. So that if so, we needed to kind of brace the kids as they're growing up so that their spine can end up straight and not cause a whole lot of problems. And that's scoliosis. Okay, so now that we talked about the vertebral bodies and the curvatures, let's talk about the nerves. So the nerves are something that's very important to understand, and this is where people get tripped up a lot. But I'm going to give you the tricks that are going to answer every single one question that they're going to be asking about the nerves in regards to your different vertebral areas. And so we talked about, as far as cervical vertebrae, there was C1 to C7. And this is bones. I'm going to write bones over here. Okay, so C1 to C7 was your cervical vertebrae bones, where your thoracic vertebrae is going to be T1 to T12, and your lumbar vertebrae is going to be L1 to L5, and then your sacral is going to be S1 to S5. Okay, so those are the bones areas of our vertebra that we already talked about. Now the nerves, however, the one weird thing is, and this is where they ask questions, is okay, if I'm in the cervical region and I damage or have some sort of herniation between C2 and C3, what nerve that comes out in between them is going to be hurt? And that is something that's very important to kind of break down. So I'm going to draw a little vertebrae because we haven't talked about this yet. But I have a vertebra, and then I have my spinous process that sticks off back here. And then I have my next vertebrae, and in between them I have my nice memory foam, which is my intervertebral disc, IV disc. Okay, and then I have my nice other spinous process that comes back here. And what happens is my spinal cord comes down, goes through the little spinal canal and keeps going, right? And comes down eventually, and that's my spinal cord here. And at each of the levels, we spit off nerves, C1, C2, and all these different things, C3. And you might be asking, where exactly do they come out? Well, the nerves come off and they go pretty much in between, right around the height of the intervertebral disc is when they exit. And so if the intervertebral disc bulges out, it's going to hit the nerve in between these two vertebrae. So if I have C2 and C3, then I just need to figure out what nerve exits under C2 and above C3. And this is very important, as in our cervical region, the nerve number, so C1, is always associated above the vertebra. So C1 is always above C1, C2 is always above C2 vertebra bone, C3 nerve is above vertebra C3, and so on, until we get to the last nerve. See, we only have 7 bones, but we have 8 nerves. And so now what happens is we have our C7 bone, but the C8 nerve comes out below it, as if there was going to be a C8 bone, but there wasn't. This bone is actually T1. It's not C8. And so C8 comes out under C7 and above T1. So now where would the next nerve be? That's T1. That comes out this way, and this is my T1 nerve under my T1 bone. And so right here at the junction of the thoracic and cervical region is where the nerves go from coming out above their associated vertebral bone to below their associated vertebral bone. And this is something that's very strange, but just anatomically kind of fits for all the different nerves of your upper arms and your legs and everything. It actually helps and works out better than if we add an extra vertebra there, especially for the perfect curvature of someone's back. And so if I have a herniation of C2 and C3, C2 above C3, and remember the nerve that goes above the vertebra, so C3 actually would be injured. Where now I get into my thoracic region, remember it switched from going above, C3 above C3, to now that we've gone past the C8 nerve, everything is below. So now the associated nerve and vertebra are actually, the nerve goes below the actual vertebral bone. So if I have a herniation between T4 and T5 or T8 and T9, you just have to remember the top vertebral number, and that's the associated nerve that gets hurt. Now, in the lumbar region, it actually not necessarily switches back. All the nerves pass under the associated vertebra, but the ones that are actually injured are a little bit different. So instead of actually depicting it here, I'm going to go to my next slide and describe what I mean by this, okay? So this is pretty much how questions go, is I have someone that got in a car accident, and they were rear-ended, and now they have severe neck pain that actually radiates down to the side of their neck or their shoulder. And then we look under imaging and we see an intervertebral disc herniation at the C2, C3 junction. What nerve is actually injured here? Well, this, remember, if it's that high up in the cervical region, C2, C3, it's going to be the nerve that goes above the vertebrae. So C3 was the bottom one, so C3 is the nerve. Where again, same scenario, an accident or a stabbing or something, going in between T4 and T5, what's the nerve? Remember, now the nerve is below. So now we use the top vertebra as the number for our nerves, so T4 to T4. And then lastly, in our lumbar region, I have to explain it with this picture because that last one doesn't really quite do it justice. So normally the height of our vertebral bodies in the thoracic region are quite narrow. We have intervertebral disc, and then we have this, and our spinous process. And the nerve only has one place to exit here, at the height of our IV disc. So when this herniates, it hits the nerve that comes out at this area. However, as we're growing from infants to adults, our lumbar vertebrae actually elongate. And so now what happens is I have my disc here and my spinous process, and then I have my disc here, and then my spinous process and my IV disc in between. The nerve that comes and exits between this one and this one comes and exits above. So if I have a herniation, I'm not actually hitting the nerve. The nerve kind of tucks right under the spinous process or the transverse processes and exits. It does exit. So if I were to say, oh, if I had L3 and L4 and I said what nerve exits at this height, well, we would say again the one that goes under this. Therefore, we have to use the associated nerve from the top. So this is going to be my L3 nerve. However, it's not the one that's injured if I have herniation. It's actually the next nerve that's coming down right here to exit the one below. So L4. So L4 runs over the intervertebral disc where it's herniating. So now this is where it's damaged. So you can see this picture actually here is that I have my L4, L5 nerve here, and my L4 nerve comes and exits. But the bulge, say I have a herniation right here, then what happens, or a bulge right here in the intervertebral disc, disc herniation, Well, what happens is it's actually the next coursing nerve that's going to be injured from this bulge. And so it's actually, if I have someone that has a disc herniation of L4 to L5, what nerve is actually hurt kind of switches back to our original thing of that L5 that we're talking about in the upper cervical region. So be very careful, and this is actually where your question comes from. It's always this one. They always ask this question. I don't know why, but they never try to trick you up. But remember, in the lumbar region, it switches back, not because of the nerve actually goes back to exiting above, but it's just that the one that exits is above where the damage is occurring, and it has to be the next nerve that's going to exit that then gets injured in this spot. So L4 to L5, L5 is injured. And so here's the classic scenario. I have a 35-year-old man doing workouts at the gym, and he lifts heavy weights, and he has a sharp instant pain that radiates from his lower back to the back of his leg and the side of his leg. And we do an MRI and we see herniation of the L4, L5 level intervertebral disc. What nerve is injured? And you just have to remember the nerve above L4 exits before that intervertebral disc. So L5, the next nerve, is going to be the one that gets injured. And you just got a free point on your exam. Okay, so last things before we kind of finish up this video, and then check out the next one for the back and spinal nerves and autonomics clinical relevance. We're going to talk a little bit about spinal nerves. And spinal nerves, so if we're actually zoom in on the spinal cord, I want to kind of teach you and break through some of these things. So we have our spinal cord here, and you're going to learn all about this in neural, but I just want to give you kind of the basics. So we have sensory fibers. So if you touch your arm or you touch your leg, we have sensory fibers that pick up different pieces of information: vibration, touch, proprioception, all sorts of things. And those will come in through your different dorsal rami and ventral rami, and eventually will come in as this blue fiber. And as it comes in this blue fiber, it has a nice kind of ganglion cell here, and this is called your dorsal ganglion. That's your cell bodies of your sensory nerve fibers. And then they'll come in and they'll synapse on this dorsal horn. And that's sensory, and the dorsal horn will carry this all the way up to your brain so you can perceive and understand what just touched you, or what just vibrated, or where your arm is found in space for proprioception. That's what this is this dorsal ganglion, dorsal root, then goes to your dorsal horn, and that's for sensory. On the other hand, in the spinal cord, we have our ventral horn, which this is actually going outwards, and this is where your motor comes from. So the ventral horn goes out the ventral root, and then will carry on to go out to your body for motor. And so this is for moving your arm. This is for blinking your eyes, all sorts of these different things. As we have, not blinking your eyes, sorry, that's cranial nerve, but for moving your neck and associated things. And so we actually have these motor nerves that kind of can come out and control a lot of your motor muscles. Spin your spine, and bend forward and backwards, do your yoga. That's where that information as far as motor comes from. It goes from ventral horn to ventral root, and then goes out to your body. The dorsal rami is something, as far as motor, is for your deep back muscles, and those are your true deep back true muscles. And those are kind of like your erector spinal muscles and such. That's not super important to actually know specifically what those are, but it's just for deep back muscles. And then the ventral rami is going to be all your other muscles, your limbs, and your like chest wall and stuff like that. That's going to be where your ventral rami carries motor fibers for those different muscles. And then lastly, the most important thing of actually why this kind of pathway is drawn out here is for your autonomics. So you might ask yourself, if you haven't learned this already, or you're coming from a background that isn't in the biology or physiology or any of that world that you've studied this before, I want to kind of explain this to you. So in our body, we have an autonomic system. And you might know this as your fight or flight response, or your rest and digest response, your sympathetic and your parasympathetic respectively. And these autonomic fibers are ones that you can't control. It's something that just happens and changes in different states. So if you're out in the forest and you see a bear or a tiger or something like that, your sympathetic's going to kick up, it's going to bump up your heart rate, it's going to dilate your eyes, it's going to close all your sphincters so you don't pee and poop, and it's going to allow you to breathe more. So that what you need to do is you need to run away, or you need to climb a tree or something like that. And that is going to be your fight or flight response or sympathetic nervous system. And now how sympathetics work is that they come down from the brain perceives information, it sees a bear. And that bear gets processed in the amygdala, which helps you to then respond appropriately of a fear response. Once you have this fear response, it sends down fibers through your spinal cord and gets to this area right here called your lateral horn. I know this says motor, but I'm going to say sympathetic. Now, sympathetic fibers are motor because they do a lot of things. They contract smooth muscle and all these different things. They increase your heart rate and such. But I'm just going to put sympathetic because that's actually more important than just knowing it's motor. It's not just motor, because you might get confused with these guys. Okay, so this green fiber starts in the lateral horn, and this is something very, very important. I could very simply throw a cross section of a spinal cord. If you see a lateral horn, you know you're dealing with autonomics in the sympathetic nervous system. This lateral horn is only found from T1 to L3. Some people argue that it's L2, but L2, L3 is where you're only going to find this lateral horn. And from this lateral horn, what happens is you send it out via the ventral root, and then it hits this little tiny section called your spinal nerve. That's it. If you ask what part of the spinal nerve, it's this little miniature, like 3 millimeter section is all that your spinal nerve is. And then what it does is it actually has to get to its own ganglion. It has to get to the central hub of sympathetics. And the central hub is this guy down here. So how do we get down there is we go via the white rami communicans, and then we come into this ganglion. Now, I can do multiple things once I'm down in this area. I can synapse on this nerve, and then this is going to be a second fiber that's going to go up to my head. It's going to go down towards my pelvis, or it's going to go towards my organs. And this is like the lungs and the heart and your GI tract. And in each of those associated sections and abdomen, when you get to GI, you're going to learn these autonomics. We're going to break them down again for you, the splanchnics. If you get to cardiopulmonary, you're going to see my new video, and I'll be talking about the lungs and hearts and the autonomic system there. So we will recap this as well. And that's all associated with this kind of branch off point here. Then when we get to neuro in your term 2, we're going to be talking about this section, which goes up kind of towards your head and allows you to have sympathetics in your face. So if you ever think, what are sympathetics in my face? Well, that's dilating your pupils when you need to run away from that tiger, so you can gather in all light situations outside, kind of figure out you want to see as broadly as you can so you can find that escape route to get away from that tiger. In addition, it causes sweating, which keeps you cool so you can continue to run away from them for as long as possible. And how do we get to that is via the this upward path towards the head. Now, one last thing, the other alternate pathway. So we talked about to organs, we talked about to pelvis, and we talked about to head. What is this gray rami communicans, this one that's highlighted here? Well, if we want to get to the body wall for sympathetics, such as my arms or my chest, I need to then synapse here, but then exit out the gray rami communicans, because it's going to then follow all the nerves that go to the body and the limbs, which are your ventral and your dorsal rami. And what is the purpose of this? Just think of what would a sympathetics do out on your arm or your arm hair, wink, wink, wink. Erecti pili muscles, for example. That's going to help you shiver and stay warm and cold. It also, in addition, increases sweating. So if you ever had sweaty arms or sweaty hands or sweaty armpits or sweaty chest or sweaty back, well, how does the sweat gland know to secrete out that sweat? Is when your sympathetic nervous system kind of pops out. And that is via this route from the lateral horn, ventral root, gray rami communicans, and then white and gray rami communicans out to the body wall. And that's important for erecti pili and sweating. and those sorts of things, in addition to like vasoconstriction in times of like cold temperatures to get that blood back to your heart. And that's where we get that nervous system responding and doing those things. And so that's pretty much the autonomics on a basic section. Each area of the body will be covering the autonomics. So when we get to the heart, we're going to understand how sympathetics and parasympathetics work. Parasympathetics are their own kind of world. And so I'm not going to actually describe it to you here. That actually comes from your sacral nerves and your vagus nerve, which is a cranial nerve 10. But you'll get that in neuro, and that's more important there. I just want you to draw out this pathway of sympathetics. And then for parasympathetics, just know it comes from the brain above for vagus, and that controls all of the GI tract. It controls all of the heart. And parasympathetics are the opposite of sympathetics. They're your rest and digest. And now, if you're thinking, I'm sitting down, I'm watching TV, and I'm eating some popcorn, and I'm resting, and I'm digesting, what's happening? Well, my blood is going to my GI tract, so I'm increasing blood flow there. That's what parasympathetics can help with. I'm also increasing all the activity and secretions of my stomach acid. That's where parasympathetics come into play. I'm also wanting to make extra saliva, and that saliva is going to help me swallow this popcorn that's dry that I'm eating. So that's also parasympathetics. And then it's a sad movie, so I'm crying, and that's also parasympathetics right there. And so parasympathetics are important for controlling a lot of different things, but it's in that rest and digest state that that's going to be turned on, and it's an alternate pathway from the sympathetics that I've just shown you here. Okay, so we've talked about this lateral horn. This is just a nice little picture that I kind of put in for everybody to see. And so I just kind of want to break down. I have this little mnemonic. It's not that fantastic, but I used to work at Target for a few years, and I worked up at the front desk. And one of my job description pieces was to recognize anybody that's commonly known for thieving from our store. And if I see them come in, I'm supposed to notify security. And it was always easy because we only had a few people that would constantly come in and steal stuff from our store. And it was very easy to spot them because they would come in and they're wearing sunglasses, and it's like 10 o'clock at night. And so I always have this like way to remember this, is that in order for me to spot these guys, I just see them and they look very sketchy with shades. And so that's the way I kind of remember this, is the lateral horn, the ventral root, the spinal nerve, ventral rami, white rami communicans, and then the sympathetic chain. So that's look very sketchy with shades, and that's the way that the sympathetics kind of come out. Sorry for that little white thing that's coming down here. I'm going to redraw this. This arrow is coming right down to this guy and pointing it here. And so that's just the retail thief. That's the way I remember the flow of sympathetics out. And you can actually get questions specifically on what parts are here. Again, if I want to go to the organs, I'm going to go by their own associated nerves. We'll talk about them in those areas. If I want to go to the body, I'm going to exit via the gray rami communicans, and that's going to go to help me sweat and do some erector pili muscles. And then if I want to go to the head, I'm going to ascend up this chain, and that's going to help me there. And you might be asking, what is this chain? I don't really see it in these kind of cross-section pictures you're describing. So let's do a slight three-dimensional drawing. I'm not going to go over every one of these things. It's a horrible picture and scary, and you're like, what on earth are you talking about? And everything's labeled. I just want to show you, here's our vertebral column, and here's our ribs and such like this. And this is where our sympathetic chain, it's kind of hidden in this corner down here, and it's running along. So here it's running up and down like this. And if I want to ascend to an area, so I can come out, go via that same path, white rami communicans, and then I can actually ascend up here. And if I want to go to the body wall up above, a synapse here that goes out of gray rami communicans, and that can go out to these things, everything I was just kind of talking about: blood vessels, skin, erector pili muscles, and sweat glands. That's like everything I was covering. If I want to go to organs, I go via the same route, but then I just go through the ganglion and go out synapse near the organ, and then I control my GI tract or my lungs and heart and stuff like that. And so that's kind of things that we can look at, is seeing when I go into my anatomy lab, and we pull out these chains in the back, you can impress the doctor saying, oh, that's the sympathetic ganglion that gets information via the white rami communicans. It goes back to the spinal nerve, it goes back to the ventral root and the lateral horn. And this is important for going to the body wall, going to different organs, and descending up in the head to the face for sympathetics. And if you do that, you say that in lab, that doctor is going to be like, man, I want to hire you as an MD already. So definitely try to impress your doctors when you're in there and doing that. In addition, it's a great way of just kind of simplifying how sympathetics are working and where they're found anatomically. All right, so that pretty much closes off this first video. The next one, we're going to really dive more into clinical stuff. I'm sorry if this was boring for you, but if you get to this point, you're watching at 1 time speed and it was boring, you should have watched it in 2 times speed. Just kidding. All right, so definitely check out our next video. We're going to be talking about clinical relevance of back and spinal nerves and autonomics. And so that's going to be showing up very soon. Don't miss out. All right, happy studying.